A very warm welcome to all of you. I'm Sanjay Kaul, heading the cardiovascular ultrasound business for G Healthcare in South Asia. I sincerely hope that you, along with your family, are safe and doing well. The vision of G Healthcare is to impact lives in the moments that matter. And what moment are more precious than when a patient is seeking care and treatment for his ailing heart? With the Vivid systems, we have consistently evolved technology to elevate clinical solutions for efficiency, productivity, and conclusive diagnosis. Today, I am excited to be standing in front of you to launch the most advanced Vivid systems till date, the Ultra Edition, which is powered by artificial intelligence and elevated by you. The Ultra Edition version of Vivid is ultra precise, offering uncompromised image quality and advanced visualization capabilities for precise diagnosis. Ultra fast. With AI-based automation tools, Echo is going to be easy, fast, and accurate, improving the workflow efficiency, reducing inter-observer variability, and have consistency across Echo lab environment. And ultra efficient. With advanced quantification tools across Vivid product portfolio, we tend to improve the clinical diagnosis across patient spectrum for better clinical outcome and patient care. Over a period of time, we would like to take you through series of clinical modules from eminent clinicians from South Asia. Today, I would like to welcome Dr. Naman Shastri, Chief Consultant, Cardiac Anesthesiologist and Intensivist at Epic Hospital, Ahmedabad. Dr. Naman has done significant work and research in the field of echocardiography over decades and has many publications to his name. We are really privileged to have him with us. With this, I hand over the session to Dr. Naman Shastri.
Hi everyone, this is Dr. Naman Shastri from Epic Hospital, Ahmedabad. I hope everybody is doing good in the unprecedented pandemic. We all are fighting against that. Being vaccinated all, we are hoping that we are not facing much more complications and problems with the deadly COVID-19. Today we are going to discuss the very important aspects about ultrasound technology, particularly the Ultra Edition. So we are starting with a very simple images that we all know. Like you can see, this is a very 4-chamber view in transthoracic apical 4-chamber view. And now in this image, what we can see is a 2-dimensional 4-chamber view where we are not aware what is happening inside the chambers. That is just pressing the 4D button and we are acquiring these 4D images. Many of us clearly see that okay, this 4D image is seen, but you can see many echo dropout at the apex area and some part in the posterior aspects, and though the 2D image is clearly seen, that is the azimuth plane and this is elevation plane. Here you can see where your axis and planes are cutting. So in the 4D images, you see there's a lot of problem happening, and you can't see very clearly thing. This is the photorealistic image technology, that is HD Live, which has got the light source, that is a single light source. So that gives a depth perceptions, and this gives some ideas about how the depth of them. Like you can see that some AML part shadow is seen here. You can see the PML part shadow here. You can see the septum is showing the shadow. So this is, you can see the difference between these two, that we are more able to have the better perceptions of the images. The basic advantage of it has got the depth perceptions, the live rendering software, where it has got a single light. So if I just freeze it here, you can see here the color can be seen here from here going up and down, and that is an advantage, that we can have the good depth perception. That by adding the HD Live, we are focusing like a torch which is going into the single axis, and we can focus and we can see the depth perceptions. This is a 4D markers, which is again a new technology which is giving our direction that okay, what you are seeing in the 2D images, where the 4D image lies, or vice versa, what you are seeing the 4D image on 2D image, where it lies. Say for example, we want to conform ourselves with the mitral valve, and we just press the mitral valve, and you can see this is a red color button. I can increase the size of the button like this, we can increase size of the button like this, and now I just want to see this mitral valve. I know this in elevation plane, this is the mitral valve, and it is focusing on the 4D chambers in the 4D view, that okay, this 4D markers is placed on the mitral valve. Now it is looking on the mitral valve. So we are sure that this is a mitral valve. Again, we can see this is a tricuspid valve. So we are now very sure. Now if I presses mitral valve here, you can see that I can hardly see the structures behind this marker. So even I can reduces the opacities like this. You can see this is a dark, this is very, very bright. Now I can reduce the opacities in a view that in order to see the structures lies behind the 4D markers. So here you can see that the what structure lies, just we want to mark ourselves, but we can see the structures behind it, and that's a beauty about the 4D markers. So let's come back to the, we can clear this 4D markers, and let's come back to the 4D. Now if I just go to the apex view, that is aortic long axis view, here you can see I am placing my light source. Now in this light source, you can see this is whole left ventricle cavity I am seeing here. You can see whole left ventricle cavity, but I am placing the light source here. You can see that once mitral valve is opening, where you can see that there is no any light in the left ventricle. Now I want to add one more light into the left ventricle. Then I can add one more light into the left ventricle. Advantage of again the flexi light is I am able to place the two light source at the same time. So in two cavities, two chambers can be seen same way. So left atrium and left ventricle both can be seen clearly. So this is an advantage of the HD color. So basically we are making the color more transparent. We can select the area of basically high velocity jet, we can see the area of low velocity jet, and we can come back to the original HD color. In flow direction number 2, so all the low velocity, the high velocity jets is excluded. We are seeing only the blue color. If we press 1, we can see the high velocity jet, so we can see from where the flow is coming. Here it shows that it seems that the flow is coming from all around the central coapting area, because there is an issue above the coaptations. So we have been going through a different application and software which has been updated into the machine. Now we'll see how it can be utilized in a clinical applications. That is what it calls applied echocardiography. So the purpose of 3D echocardiography, the 3D 4D images, is to just see that okay, something which was seen very clearly on 2D, is there something hanging other way around, because we are not cutting our all the section in the same plane. So this may be some variability in the plane, and we don't know exactly where other things lies, and that's very important things in the 4D technology. Now here again, by using the more realistic images, or realistic photogenic images, we just press button HD live. Now you can see what difference does it make. With the addition of the HD live, you can see here the depth perception becomes more better. Again we can freeze it out. With this we can change the light source, and you can see that you can see the very nice beautiful shadow all around. We can see the shadow of the septum, we can see the shadow of the mitral valve, we can see the septum of something hanging mass on the either side of the septum, and you can see it very clearly. So here you have to rotate your light sources, and you can see here you can place the light, you can see here, and that you can see where if you rotate it like this, you can see that yes, you can see the mask which is hanging here. And so basically these two masks which is hanging from the septums are, though level is the same, but the depth is different. So we can see the simultaneously by you have added one in flexi light, you can see it very nicely, 3 cusps which is opening and closing. We can change the light depth map, different light depth and map, and you can see that okay, this is also a beautiful way of seeing the 3 cusps opening and closing there. Again we are not sure which cusp is which cusp is septal, which cusp is anterior, which is posterior. Again, we have the facilities to see that. So here I am just changing the light source here, so you can check it very brighter way. We press the 4D markers. In the 4D markers, we just press a tricuspid valve. In tricuspid valve, this is what the size is a little bit high. I just reduce the size because I want to mark it, and this is, since it is focusing from the left ventricle, I have placed my 4D markers in the left it is from the right ventricle. I have placed it on the right ventricle, and now I am very sure that what I am seeing here is the septal leaflet. So septal leaflet, here you can see this is another leaflet. Now in surgeon's view is as I said, I am just taking a 2-click crop in an area of interest. Here I press 1, I am looking from the left atrium, and then I am just going down and I am seeing the mitral valve. Now once I can use the 2-click prop, I have an added advantage that I can view the mitral valve simultaneously from both the side, from the left atrium as well as from the left ventricle. So I just change the layout, I just press the flip crop, and you can see this mitral valve is focused from the both of you. Now many of you must have noticed that still there are some the protuberance and some color images is looking blurred. So best thing is I just pressed HD. Now on the left image, when my screen is focusing on the left side of the images, I have pressed the HD live. So you can see the difference of pressing of HD live without HD live. Now you can see that the beauty of the 4D, that not only you can see that both the valve both from both the side, from the left atrium as well as from the left ventricle, but we can see them both simultaneously. Whether this is A1, this is A2, or this is A3, or this is surely aorta, this is which segment of the posterior mitral leaflets, we are not sure, and we want to be more sure that okay, we are seeing this is a mid-esophageal long axis view, is a zoom mode of the mitral valve in a mid-esophageal long axis view. Now we want to just indicate which segment we are seeing, and that is for our benefit. Though we are seeing in NFS view, but we want to see it in a 2D as well. As you can see, this is a whole A2 part, so you are seeing basically whole, this is the A2 part. Now this, if I am going to the mitral valve, this is showing the P2. So what we are saying is A2 P2 segments. So this is confirming this whole leaflet. If I am just traveling to the whole leaflet, it is cutting from the edge to the base. It is not cutting side to side, but you can see it is cutting. So if I am just traveling from the whole leaflet, you can see I am cutting from the edge to the base, and this is whole A2 segment is seen. Same way into the P2 segments, I am just traveling the whole P2 segments, and you can see that I am traveling to the P2 segments. What we are saying is the A2 P2 segments. This flexi light has totally changed the scenario of the mitral valve in the NFS view from the surgeon perspective. What you were showing it is amazing. Like you are seeing the glory of the mitral valve leaflets from both the side, and this is 100% showing that these leaflets are normal in characters, normal in structures, and you can see the up and down here. You can see the beauty of the AML from both the side, which is the side of the aorta. For the newcomers, what we can say that okay, you just turn your this 4D markers in a level of aorta. So you can see this here, this is a aorta, right? You press the 4D markers there, and then you know where the aorta lies. So here, once you have placed the 4D markers, now wherever you are going, you can see wherever you are going, you can see that 4D markers is moving perfectly all right, and you can see the aorta, you can see the aortic valve leaflets very clearly seen. We can add the lights. We can see the aortic valve. Now I have pressed the light there, and then I have just rotated. You can see the aortic valve very clearly. Why I could see this aortic valve very clearly? Because I have placed my 4D markers there at that particular level, and I have just taken a view from the different angle. See, this is what I was looking for, the anterior mitral leaflets. Now I am focusing here. Once we have a beautiful way of looking at mitral valve from the NFS view as well as from the left ventricle view, you could show it very well. you could see the color flow exactly. We could understand that it is coming from the A2P2 by use of 4D markers. There is no any cord ruptures, there is no calcification, no restrictions in a systolic and diastolic phase both. There is only restriction in the systolic phase. So it looks probably more to the ischemic MR. For the ischemic MR, you can see that only the restrictive annuloplasty works very well. So we just discussed with the surgeons, and surgeon has placed the ring, and you can see that the ring is clearly seen here. Now again to the ring, we just place the flexi light, and you can see the areas totally you can see beautiful. So in that case, we can select the translations, and we just cut the translation in a way that we just cut the just posterior aspect, and then we can see the complete AML here. You can see this completely AML because we have cut the posterior aspects and posterior part of the ring, and then we can see that again by with the use of flexi light, you can see the whole anterior mitral leaflet is moving up and down. I use the 4D auto mitral valve quantification. That is a software. This is a very easy software which can give an exactly idea from where the mitral valve can be aligned. Here you can see that this is a P1A1. So we are cutting the angle at the level of P1A1. Now it is mentioned, it is a green color part which is showing the P2A2, and this is the P3A3 part. So we have gone much posteriorly, and we are seeing the angle of the P3A3. Why it is important? Why we want to compare all the three planes? So first we have checked with P1A1, and we have found that all the complete alignment is perfectly in the plane. Once we go to the P2A2, again we can see that whatever alignment we did is in perfectly plane, and more we had gone more posteriorly, our alignment is also touching perfectly well. So whatever the results we are getting is the perfect results what we can see it. So this is the best way of reconstructing the mitral valve, and look at the surgeon that see there is no gap. You can see the very nice annulus. So this complete worksheet gives an ideas actually. Most important which I am really looking forward to is the mitro-aortic angle, and this angle has very clinical utilities, and this angle is 115, and it is said that if this is less than 100, it has got more chances and probability of developing the SAM in the post-operatively. So this is an important aspect which is just given us with the press of a button. We will just go ahead with the more applications and more cases next. Like this was a case which was showing the moderate plus mitral regurgitations, and then the patient was subjected for CABG and with or without mitral valve repair, and the surgeon wanted to discuss with us whether we need to do something with the mitral or not. We just had started completely analysis where we have put our color flow on the short axis of the aortic valve. We just found that aortic leaflets are also not the best aortic leaflets. So like we found that okay, this is just mitral regurgitations, and still we are not sure from where it is regurgitating or when it is coaptating well or not. So then we said wait, we have to evaluate this valve if we can do something for this valve. So then we had moved to the next level, and that next level was the flexi light. As I said, the advantage of the flexi light is that you can see I have just changed the depth map, and you can found this the depth map is showing a beautiful mitral valve. I can zoom it for you. I just changed the depth map. This is what we are saying, the left coronary cusp. This is a left coronary cusp. This is what it is saying, the right coronary cusp. This is what it is saying, the non-coronary cusp. So we just wanted to see where the problem lies, and what we found that if you see that left coronary cusp is hardly moving as compared to the rest of the cusp. You can see the commissure is widely opening, and this can be clearly seen with the advent of the flexi light. You can see that opening is clearly seen here. The opening is clearly seen down as well. You can see that, and that's what we can explain this the best way if provided you can see the commissures from the commissures very clearly, and that if you press it like this with a routine 4D echocardiography, you cannot differentiate very well. You can see that yes, our right coronary cusp is moving okay. This you can see that okay, this non-coronary cusp is also moving okay, but what about, yeah, there is partial restrictions, but when you place the flexi light, then you can see more clearly that the left coronary cusp is not moving well. If you want to see it You can see here, if I can just show it in one angle, you can see that a lot of calcifications seen at the level of the commissure, which is restricted. And that same way you can see it on the 2D azimuth images. You can see this part is totally calcific part. Now again, which part we are saying is, we have to say it. Now here you can say, okay, this part, this commissure LCC cusp is looking okay. You can see the RCC cusp is okay. There are a lot of calcium sliding at the level of the commissure, which is between the LCC and RCC. You can even see it from the left ventricle aspects by the help of 2-click crop technology. I am just pressing this technology and you can just do it from the LV aspects. The patient was referred for the CABG, plain CABG, and on transthoracic echo, we did only transthoracic echo, which was showing the moderate AR, mild to moderate AR. But believe me, looking at these regurgitations, quantifications, anybody would not do this valve for any interventional. On the 4D assessment, flexi-light we have added, and flexi-light we are just bringing down to the edges of the aortic valve. Fenestrations is looking at the edges. Here you can see the gap. You can see the gap between the at the edges, at the coaptation marking of the entry of the leaflets. This is a non-coronary cusp. Here also, if we just change the direction up and down, we can see that this also has the, even you can look at the edges. These edges are also fenestrated, and this part is also fenestrating. The region of AR, otherwise the aortic cusp was looking very clear, but the region of AR was the edges of the cusp which was fenestrating. And then we discussed with the surgeon, finally agreed that this patient needs aortic valve replacement, better to place a bioprosthetic valve and let the patient become completely normal. Otherwise these patients will keep on tearing by the fenestrations in the long standing, and then these patients may come back with further issues. So these were two important cases. The cases were looking normal in preoperatively, and then they found these cases require some aortic valve interventions. So then we will go to the next cases. So what we can do to make it more clear and we can understand which is the best way of understanding the level of alignment where we can have the better vena contracta. So then what we did is we started doing the 4D echocardiography. Now again in 4D echocardiography, this image, if you see that this image doesn't give you any kick actually, or any excitement that yeah, we'll find out something better. Now again, looking even the zoom mode, there is hardly any coaptation deficiency which is seen here, and we can see that okay, leaflet looks okay, there is no tethering, there is no significant calcifications or no cord ruptures or commissures opening, commissure to commissure, very good wide opening, and from where the mitral valve is regurgitating. So then we move to the another image. Our aortic valve is lying here, so what we can do is we can just use the 4D markers, select any of the markers and just see that okay, our area of interest is where it is lying. So aortic valve is lying somewhere here. So we can see that this is anteromitral leaflet, this is a posterior mitral leaflet, and what we are again cutting from the A2 P2, this is P2, this is segments of A2. So our aortic valve lies here, so we know exactly where the aortic valve is there. So this is just for understanding that what we are looking for is perfect or not. So flexi-light gives a real understanding that how the leaflets are. Leaflets looks okay, reasonably okay. There is no much calcifications, any restrictions, except some restriction is there in the posterior mitral leaflets. If you can notice that PML is partially restricted as compared to anterior mitral leaflets. You can clearly see in that AML is opening very well, but PML is restricted. And then once we just pressed a color flowmetry, so now we want to exactly locate the place where it is regurgitating. Most of the part of the regurgitation is coming from the posterior aspects, posterolateral aspects. So what we can say that these part, the regurgitation zone is P3 A3 part. This is A3, this is P3, and this is more coming from the posterior aspect. Posterior mitral leaflet image, you can see there are very high restrictions as compared to the AML image, and that is the reasons why, because of posterior apical displacement of the left ventricle cavity, which tether the cords towards the lateral aspects, which makes posterior mitral leaflets more tethered and more restricted, and that was giving some idea why PML is restricted. That could be the tethering of the leaflets because of the dilatation. And then we have placed the color. The best way to do the vena contracta is make it a freeze, and then you can adjust and align, and then you can do the scrolling. You can see that opening and closing very clearly in the direction. So here you can measure the vena contracta, you can see the very nice flow convergence. You are very sure that it is coming from the A3P3, and that was the reason why you were not being able to see that or appreciate in the 4-chambered view. Now after that we realized that, oh, it is significant MR. We just wanted to focus more on the aortic wall, how the aortic wall was looking, and there is some tricuspid regurgitation as well. Now in aortic wall, again we had a mind that can we do the commissurotomy and make it more perfect, but you can look at the aortic wall. This is the cine loop, this is the cine rotate. We just stop it cine rotate, and we can see that opening is totally restricted, and this restriction is because of nothing but because of the lot of calciums on all the cusp, particularly on the right coronary cusp there is a calcium, the left coronary cusp, the right non-coronary cusp flooded with the calciums. You can see the restricted opening. So, and this, there is, you can see even the gap, the non-coapting gap is also responsible. You can see this is a non-coapting gap is responsible for regurgitation as well, which is this leaflet, and we are not sure that in the elevation plane which is this leaflet. We just press the 4D markers, select one marker, and then we just take down this. We just stop this cine loop, cine rotate. We just take 4D markers again, select one 4D markers. We just take this 4D markers here, and here you can see that. So this is for non-coronary cusp, you can see that. So whatever area we are just looking for is a non-coronary cusp. So again, on 2D plane, we were not very sure that this leaflet was either LCC or NCC, but placing the 4D markers, we could really get to know that this is the non-coronary cusp. You can see the heavily calcifications on the right coronary cusp, left coronary cusp, and non-coronary cusp. Every cusp are heavily calcific. You can take it here as well. You can see that this is the non-coronary cusp. You can see this is the left coronary cusp, and this is right coronary cusp. All these cusps are totally calcific. So there is no point of repairing this wall. So then we can go to the next case, and that's clearly seen. It's a case of mitral stenosis. I'm just turning, I'm looking more towards the left atrial appendage. You can see that I'm just turning my translation, my rotational movement to the left atrial appendage side, and you can see that how beautiful the clot is seen here. You can see the complete LA appendage level. Except this opening at the mouth of LA appendage, there seems to be LA appendage very clear. You can see in all the directions. The rest of the things seems to be okay, but yeah, there is significant LA clot which is not in the appendage, but it is at the level of the mouth. Then this is the mitral stenosis. You can see here. You can take the options of translations up, and this flexi light also can show us a very nice way of looking at the LA appendage clot. And you can see this is the level of mitral stenosis, LA appendage. Now if I want to be in a proper anatomical position, I mean for 4D position, this is the position which I am looking for. Now if I say like this, it is very difficult for me to locate exactly what is the mitral area. Now to look at the mitral area, you are not clearly seen. The reason behind it is there are so much fibrosis, calcifications on the leaflet on anterior as well as restricted, which is a posterior mitral leaflets. You can see that PML is significantly restricted. AML is there, but it looks fibrous, thickened leaflets. So in that case, the best way is again the flexi slice view. In flexi slice view, what we are supposed to see is what is a mitral valve opening area. Our area of interest should be selected, align it properly. We are just going at the opening point. This is the area where the mitral valve is opening. Again, the second place which we are aligning, or a practice you can align is better way. This is just a area of opening, we can say it. We can just make a little more U-turn where it is clearly opening it up. Now we just see the layout. On this layout we can see that opening and closing. Best way is to just change the frame and see the what is the area of opening. Here you can measure by the area, because this is a 2D. You can measure the area, and you can measure the area and come down to the exactly level what we are facing it. If you have a doubt about the LA appendage or LA clots, this is a very easiest way to go to the 4D view. Even in the 4D view you can go with just go up and down, and you can see, you can even take a rotations. You can take a rotations here. We can see the LA appendage very clearly. We can just encircle and have a complete exhibitions of the mitral valve very well. Then you can go with the use utility of flexi light. We can go with the flexi slice for measurement of the mitral stenosis, and we can exactly know what mitral area we are facing. So here if you see that only one segment, that is a P2 involved, then can we just put it as in a fashion of fibroelastic deficiency? No, you just look at this rest of the, you can see the rest of the whole leaflets. These rest of the whole leaflets are also bulging, they are defective, though it is not protruding to the left atrium, but this is a purely myxomatous disease. And if you press a press the flexi light, you can see that very clearly both the leaflet which is bulging. You can see in the side plane, you can see that both leaflets are bulging. So this is beyond doubt, it is a myxomatous disease of the mitral valve. So it looks beautiful, but once you put the flexi light, you can see the very good depth perceptions, how depth it is. So this was the case to show the P2. Now this was the case where we have done the mitral valve repair. We have to decide where the aortic valve is here. We can select now. If you are not very sure, you can select, this was the part of aortic valve. Of course you can see some part of aortic valve, so we can press here, and we are very sure this is a aortic valve. Then we can just rotate, where you can exactly see what it is happening in the mitral valve. Now here I freeze it and I close it button, and you can see that some part is here which is fixed. So what they did is they have the club the P2 and P3 together, and that is very important. Your AML and PML is just going perfectly the way it is. And if I do the flexi light, in flexi light you can see the AML is going up and down very well. Even in this case also I can do the 2-click crop, and you can go up and down. You can see the how once going down I am getting the AML into the picture. You are going to the AML in the picture. You can this setting, this is also you can do it. You can do the flip crop, and in flip crop you can add the color, and here also you can see the opening and closing from the LV apex aspect, and you can see that there is totally competent mitral leaflets. This was a view to see the 2-click crop, seeing the simultaneously coaptation of the mitral leaflets, and the third is for the mitral post mitral repair. So this is again a very bad mitral valve which we opted for repair. In flexi light you can see that some posterior mitral leaflet is an issue, and further we are just trying to make it more clear. Yes, with the flexi light we could see that some part of the posterior mitral leaflet, that is a major part from P to P3, is projecting inside the left atrium, and then it has totally made us totally clear idea that okay, in this view you can see this is a lateral plane. In lateral plane you can see this is the right side is the posterior mitral leaflets and left is the anterior mitral leaflets, and you can see that it is not allowing the posterior mitral leaflet is not allowing anterior mitral leaflets to come up, and that is nicely can be seen if you use 2-click crop. And this is what you can see here. You can see this, you can see the lateral plane and very well. Now you can see some part of the anterior mitral leaflets also affected here, what they could be seen here. And then you can just show the direction. What I just really want to show here, that if you see that the complete direction in the regurgitation form is just turning here and hitting to the A2 part. You can see that while it is closing, the whole regurgitations hitting to the PML and coming straight away to the A2, and that is creating the jet lesion. When you see many of the times in chronic regurgitations, they form the jet lesions. That is a bad affect tissue of that particular opponents of the regurgitations. Yes, so what you are seeing here, the complete view here, the complete view which is here, you can see that it was a PML was like this. The color was going from here, going down and hitting here, and this is creating the jet lesion, and that lesion is very, very, very important. Now in this case, you are seeing that patient has got significant mitral regurgitations, and some part of aortic regurgitation jet is also coming. We are not focusing on the tricuspid valve, but we are probably assuming that it also should have been some impact on it. Now if we just go with the 4D, like as we press the button with the 4D, before we just go to apply some more, it is very interesting that we move around the images. You just move around the images. This is what the rotational images we are doing it, and these rotational images gives you complete ideas exactly what lies where. Like you can see that both the valves are faced from the top. You can see that I am just changing the translation, and I am seeing the rotational part of the aortic valve as well. If I just put the flexi light here, flexi light, you can see that the jet is reaching till level of the mid LV cavity. So I again stop the flexi light, but you can see how nicely you can see the 3 valve regurgitations very well easily. And again you just come back to the locations, original locations. You can see here the mitral regurgitations and tricuspid regurgitation. So this is probably the case of triple valve repair. Where the tricuspid leaflet, it should the septal part of the tricuspid leaflet should be at the bottom, and again you can place the 4D markers. You can see that this is a septal leaflet, and this septal leaflet is clearly seen. So this is a septum. You can see this is a septum. You can place your 4D markers here, and you can see the septum here. You can go a little down. You can just traveling on the septal leaflet very well, and you are going in this, you are traveling further against that, and you are seeing the intermitral leaflets. Suppose if you are not very sure how to take the image very well, again you can do it by 2-click crop images, and in 2-click crop images also shows the very nice tricuspid leaflet. You can see, we can appreciate all the leaflet and cusps very well. Again, if you have a doubt about which cusp is this, better use this 4D markers, and in the 4D markers you can say that okay, this is the septum. You can say this is a septal, this is a septum. So naturally the one which is downside here is the septal leaflets, and one which is against that is the anterior leaflet. So you can utilize this very well with the help of the 4D markers. So this beautiful tricuspid valve is seen. But for that they need certain parameters, they need certain measurements. The measurement, as I said earlier, like you have to know exactly what is tricuspid annulus length, what is coaptation height, what is coaptation volume, what is the region of tricuspid regurgitations. Everything can be done with this. But if you have the better quantification structure, quantification tool that give you a better idea about measurements, and that what we can have it, like if you just press a measure, go to the valve, go to the TVQ analysis, it is processing, and in the processing it is giving you complete analysis about the substance, like it is annular to area 2D this much, perimetry this much. Like if you say 4 chamber, there's 2 chamber axis, these are the 4 chamber axis, this is that's what we see. This is the 2 chamber axis anteroposterior, this is a major axis, this is a minor axis, the diameters, all these things can be seen very clearly. Coaptation point height, which is seen here, we can just go up, we can see the coaptation height here. This is what they measure, the distance from the annulus to the level of coaptations. So everything, and in spite of that, not only that, it gives an idea about the tenting volume, and this volume gives idea that how much functional tricuspid regurgitation is there. Here this is the case after repairing. This is the case after repairing. You can see that. So this is the locations. If you press color or not, you can see the difference location. Now where it is, you know, the tricuspid leaflet ring annuloplasty is never a complete ring. It is a ring which is spared at the level of nodes, node fibers. So that is the level where there is a maximum weakness is there to hold the annulus, and that is why you maximum time you may get the tricuspid residual regurgitations at that particular level, and that's what we are seeing here. You can see here exactly, even you can see from the down, you can see the exactly the level of the regurgitations jet, and here you can appreciate very well. In zoom mode, you can see here how the leaflets are coapting well, and you can put a color also, and you can again confirm your finding that it is at the level of septoposterior where it is regurgitations. You can even do it here also, you can do it 2 clip crop. In 2 clip crop also you can see the exact locations. You can see it from the bottom as well by flick cropping. You can see here the location as only 1 point. So after repair of the previous patients, that is a bicuspidizations, you can see that the data is totally clean, neat and clean as far as the repair is concerned. Here now there is a catch. Sometimes a lot of hazy picture is seen here. You can see the picture is seen very hazy, but you are not sure whatever there is a leakage or not leakage. Again, I will put it HD color. In HD color I see the transparency, and in this transparency I will make it more transparent, and you can see that the leaflet movement is seen very well. But if still I just go to the flow direction, in flow direction you can see that there is no flow which is going towards the probe, and all flow what I am seeing is going towards the away from the probe. So whatever we are seeing is the thing which is going away, and that means the patient has got no literally no regurgitations. So the journey of 2D to 3D, 3D to 4D, and beautiful addition of ultra addition software really makes me say wow. Not only that, intraoperative the surgeon say that wow, what the images, and that images create them to use, waiting for us to say that how is the mitral valve repair, how is the aortic valve repair, how is the reconstruction surgery of the ventricle, how is the reconstruction surgery of the congenital heart. So this beautiful thing is been possible with the advent of the ultra addition kind of the software, and that software has really made the life so beautiful that today everyone is waiting for it, in whether we are talking about the cath lab or we are talking about operation theaters. And believe me, our own colleague has started realizing the impact of these beautiful applications. Thank you very much.